My name is Jerome Dendura, and I'll be facilitating the sessions again today. I'm here accompanied by Mathilde Cornu from INTPA G4 unit, in charge of reducing inequalities, but also health and education and social protection. I'm here accompanied by Mr. Bernd Appel from G4 unit, our health lead today. We'll be going through three sessions, sorry, a bit more challenging as a menu. This morning we'll be tackling how to reduce inequalities through the health sector, and Bernd will take us through the maze of understanding inequalities in the health sector and the issues linked to inequalities and equity or inequities with regards to health. It will be accompanied here this morning by Joe Kutzin from WHO, specialized in the health economics, who has written quite a number of articles on that, and will take us through issues with regards to inequalities, measurements, data, and the financing. And then we'll get an interesting presentation from our colleagues in Morocco, down to earth, presenting to us what they've been doing in the health sector, their experience using budget support, policy dialogue, what they've been able to do with regards to universal health coverage, and which lessons they draw from this experience. So again, a very interesting session that will lead us to a number of questions. We'll be able to raise few Q&A. And just for you to know, this afternoon we'll have two sessions, one on food security and nutrition, and one on the environment and climate change. Obviously, not disconnected from health, because food security, nutrition, and our environment are directly impacting on our health, and our health directly impacts on our opportunities in life and how we can go through education, decent work, and using our capabilities. So with this introduction, I'd like to give first the floor to Mathilde Cornu from G4 for a quick word, and then we'll leave you the floor. Bernd? Okay.
Thank you very much, Jerome, and welcome you all to this third day of the Inequality Week. Just want to say thank you to you all for participating to this first day. So as you may know, so the Inequality Week is a pilot project. It's the first time that we're organizing it. It's a 5-day seminar with 2 main days dedicated to compensation. The first day was dedicated to concept, general definition, measurement of inequality, and the last day will be dedicated to the I marker. And the second, third, and fourth day, we have our great thematic session, and today's health session. So I wish you all a great session, and thank you again for joining.
Very well. Bernd, the floor is yours, and when you're ready for our questions to our participants, you let me know.
Please, you can start the questions now, because while I do my introductory remarks, you can start answering the first 3 of altogether 5 questions. The first 3 are a bit more general in nature, and the other 2 are a bit more specific in relation to Joe Kutzin's presentation afterwards.
Very good.
My task is not to answer all the questions on health and inequalities or inequities, but also to give a bit of a food for thought and introduction into the topic health and inequality. The guest speaker, Joe Kutzin, will give an appropriate overview of the equity challenges on the path to universal health coverage from the perspective of the World Health Organization, representing all the ministries of health in the world. And our colleague Oliver Weil, from representing the European Union delegation in Morocco, will give a very practical example of how the European Union in Morocco addressed inequalities in health. This will be followed by questions and answers. So please feel free to answer the questions while I'm going through my own presentation. I will refer to this one either during or at the end. The first question is, I have to go to read now. What are, in your views, the top 3 social factors that create ill health? Yeah, that basically make you sick. The second question, where's the second question? What are the top 3 actions that can be taken to improve health outcomes? in your perspective, and try to restrict yourself to one, maximum 2 words, and the rest will be done by the algorithm. They will hopefully reproduce a nice picture for us. And the third question is, how would you distribute the relevance of health between social factors, individual genetic factors, codes, access to healthcare facilities? What do you think, if you have 10 points to share, where would you give 1, 2, 3, 4, 5, up to maximum of 10 points for each, so that it adds up to 10? Thank you very much. With this, I will start my presentation, and we'll come back to this towards the end or at one or the other slide.
Excellent. Thank you so much, Bernd. I'll let you get ready for your presentation. So just to make sure everyone is ready, these 3 questions are there on the platform to be answered as we go through presentation. You have the link in the chat of the Zoom that you are seeing. Please go ahead. Again, it's anonymous, so we welcome all answers, and answers can help us also better understand your positions, your context, so this will make a fuller presentation. Over to you, Bernd, for the presentation.
Good. I labeled it health and inequalities, and it's a long-lasting challenge. And the second notion is referring to health being, is it a medical science, is it a natural science, or is it a social, political, and economic science, or in this case, also a matter of social justice? There is a challenge of how do we actually measure health? And I will come back to that later, and I think also Joe will refer to this one a little bit. And also a question, can 2 persons actually be equally healthy? If we talk about inequalities, the whole notion comes from income inequality. So while people can measure income and say, this one has $2,000 for this work and this one has $2,000 for this work, but in health, it's slightly more complicated way. And one thing we always or often misinterpret or mix up is the challenge between, are we talking about health or are we talking about the consumption of health care? These are 2 very different concepts and things. So I have to learn how to press to the next slide. And with that first slide, I would like to address the issue of these 2 words, inequalities and inequities. In the health sector, we prefer to talk about the inequities, whereby in development cooperation in general, people talk about inequalities or prefer to talk about inequalities. And let me take those 2 notions, the one at the top and the one at the end, to highlight this one. With health inequalities, we refer to, in general, to measurable differences in the health of individuals or groups. So we can measure people's heights, weights, blood pressure, blood sugar. We can measure liver function tests. We can measure kidney function tests. You can measure his endurance, the time he needs to run 100 kilometers or to climb 5 floors. All these can be measured, and we can measure the differences between people or groups of people. Per se, this is really nothing bad as such. It becomes a challenge when we measure health differences, which are or would be in principle be preventable and unnecessary. And allow them to persist would mean they're unjust and not able to be justified on moral grounds. We therefore refer to health inequities, which is basically measuring an inequality and adding a moral adjustment to this one. And describe health inequities as systematic differences in health outcomes that could be avoided or by reasonable means, under the set circumstances of this country, of this social group, of this entity. And the picture on the right depicts this quite nicely. You have a tall person, a medium-sized person, and a disabled person in a wheelchair, and they want to watch a football game, and there's a fence, and they all get the same sort of box to stand on top to be able to watch that without paying entrance. That means everybody is being treated equal. He has been getting the same thing, but they only 1.5 can actually watch the football game. Equity would actually mean that people their needs have been addressed in a different manner, so that all 3 at the end can watch the football game. With this, I would like to go back to the time when I started medical school. The declaration of Alma Ata, where the WHO announced at the first international conference on primary healthcare. That was when I finished my first year at medical school. It doesn't mean that the discussion started in 1978 on seeing health as a political challenge, but it was the first time that I actually came into across this one. And that time, the Alma Ata Declaration defined health. Now I have to get a bit closer because my eyes are not really very good. As the highest possible level of health. What is it that what are we able to achieve with the given resources, and recognizing in the second statement that health is not only a responsibility of the healthcare sector, but that there are other political, social, and economically unacceptable preconditions which contribute to ill health within the country, but also in between countries and regions. This was re-emphasized 30 years later, though we are now in 2008, the WHO put up a commission on social determinants of health. It doesn't mean that nothing has happened in between, but not enough has happened that the health status of people have approved in a systematic way. Yes, it was true that people are basically living longer, they're vaccinated, and people are having longer and better lives, but not to the extent to what it would be possible. And I come back to my first, to the second slide where I talked about inequities. Can these differences in measured health differences be addressed, and can they be justified? And 30 years later, one could still to state that there are differences between the health of groups and individuals living in certain parts of the world, which are not really necessary to accept. The WHO Commission on Social Determinants of Health has basically highlighted 3 ways of how to address this one: to improve daily living conditions, to tackle the inequitable distribution of power, money, and resources, and lastly, to measure and understand the problem. And if one has measured and understood the problem from the health perspective, one needs to assess the impact of different actions inside the health sector, but in particular also outside the health sector. There was one slide missing. Wait, how do I go back?
Like this?
There was one slide missing where, okay, there was one slide missing where I was looking at examples of the healthcare sector. But I can also talk to this one. It's fine. Maybe I was hiding it. This next slide tries to link. No, I will press. Thank you. Tries to link how to tackle determinants of health and link it to the healthcare sector itself. People often believe that health is determined by the healthcare industry, and I would like to put this into perspective with blocks to show how relevant other sectors are. We first have to talk about the socioeconomic and political context of a given government, of a given state, and look at governance, macroeconomic policies, social policies, public policies, cultural, societal values. Yesterday, we were talking about fiscal policies, very, very important. And look then at the socioeconomic position of an individual in this particular country. To which group does he belong? Which educational status does he attain? Which occupation does he have? And what income does he achieve? All this one would address as structural determinants of health inequities. If this comes now to the use of the healthcare system itself, there are still material circumstances which determine whether a person accesses a healthcare system. Yeah? The distance between his house and the healthcare service, or the work or the place where he's working, his behavioral and biological factors, and his psychosocial factors and circumstances. All this leads to him accessing the healthcare system, which will then have sort of an impact on his health. So if one depicts this in terms of bubbles, then the health system actually becomes less relevant than many people believe it is. And we have to relate this person also to the group he is living in and see how the social cohesion within this group. Let me skip this slide, and I would like to go straight into this one to add on what I've been just saying. What determines actually length and quality of life, and where do we put our money? And maybe here I can refer to at least the three questions before I actually explain this one. Can you switch on the MKS slide to see the results of the three questions?
Let me move straight to that link. These questions, right?
Yeah. The first three questions.
Okay, let me remove these for you. That's it.
What, in your views, are the top three social factors that create ill health? So
these are the answers.
These are your answers.
You can do it in categories or in word cloud.
Leave it at the cloud, because the right things are in the middle. It's poverty, it's water, it's education, it's access to services, condition, and nutrition. So poverty, nutrition, water feature very strongly. All these things are happening before actually people access the health services. The second question was, what are the top three actions that can be taken to improve health outcomes? Health is in the middle. If this is related to healthcare services, then it is not really a picture mirroring the first slide, whereas nutrition, insurance, quality facilities, quality services. So for me, there's a mismatch between what contributes to ill health, poverty, nutrition, education, water, and sanitation. And what do we do to improve health? The logic would be a little bit to address those drivers of ill health. And I will come to that in the slide I was just putting up. How would you distribute the relevance of health between social sectors, individual genetic codes, and access to healthcare facilities? People have not answered that.
Maybe we can leave it for colleagues to answer.
Not answered that question. Maybe
No.
get back to that later.
Go ahead.
Jerome, you can maybe click on the latest round results on the three dots, then we can see it. No problem.
This one.
And then show latest round results. Okay.
That's it. I've got this one.
And on the right, you also see the distribution.
So you see they are.
Okay, I mean, people distributed equally between social factors and access to healthcare facilities, and half the point and half the relevance only to individual genetic codes. That's interesting, especially between the first and the last, between social factors and access to healthcare. Maybe let's go back to the PowerPoint presentation and show again that graph. Exactly. If we look at the left side, we will see sort of the green bars. We look at programs and project policies. That is what either programs, what we are doing, policies that what governments decide, health factors which are contributing to health, and health outcomes. Health outcomes being depicted as mortality and morbidity, which means how long do we live and how ill are we during this period of life. And what actually contributes, and then one can argue about the different percentage allocations, but we have, that is a university paper from Wisconsin, which have depicted this one. What is the contribution of the physical environment to health? What is the contribution of the social and economic factors to health? What is the contribution of clinical care and health behavior? And clinical care access actually was only contributed to the value of 20%, which means 10% access to care and 10% the quality of care. The other 80% contributing to health factors were allocated to other proportions, to the health behavior of the individuals, how much he was smoking, drinking, and having unsafe sex, walking, his whole lifestyle. Social and economic factors, his education, his employment, his income, his family and social support. Those of you who watch CNN will see as moderators and presenters of CNN usually very lean and slim people. The moment America goes onto the street and shows the ordinary American, you will see people of double, triple, or quadruple the same size. And these are the majority often in the public view. So there's a distortion of how we see often ourselves, the physical environment. The right side tries to depict The left column, the contribution to mortality reduction, and the right column sits how do we spend our money. And if one looks at the left of these two standing columns and the top yellowish one, it's 10% allocated to the healthcare industry, which contributes to mortality reduction. The blue one means lifestyle. Yeah? So if we change our lifestyle, or the contribution of lifestyle to ill health is considered between 40 and 50%. The white block is the environment, and the reddish block is our biology, our genetic code. And if you see where we spend our money to address ill health issues, we spend 80 or 90% of our money to address 10% of the issues, and we spend very little on lifestyle, environment, and addressing biological factors. So if we want to really address health outcomes, maybe we have to reconsider where we are allocating our money. And in health economy, or in economic terms, we are talking about allocative efficiency. Are we allocating our resources to achieve the maximum result? If we talk about how we spend money within the healthcare sector in order to get the best possible contribution of the healthcare sector, we talk about technical efficiency. How well do we spend the money within the healthcare industry to get the most out of that contribution? I won't say too much about this famous cube. Some of you may know this one. Joe will spend a bit of time to this one later, but it's basically how the Minister of Health looks at this cube. And sometimes this Rubik cube can drive you actually mad, trying to square the circle, trying to get the resources, allocate the resources within this dark bluish tube to cover as many people as possible with as many services as possible, healthcare services as possible, without asking them to pay any amount of money. And each Minister of Health across the nearly 200 countries in the world has to play this Rubik cube game to get this within the limits of this the financial package in this particular country, to get the best out of this allocation exercise. I would like to refer a little bit to the EU external action, because we are sitting within the European Union Commission, and would like to refer to the Global Health Strategy of 2010, which addresses equity and health in all policies. So this is not something really new. The EU Consensus on Development, dating back from 2017, re-emphasized this one. Providing equitable access to health services in our partner countries and supporting partner countries to do this one in order to achieve universal health coverage, and also address at the same time economic and social inequalities, which will actually build the foundation for better health. This was picked up and reaffirmed in the new Global Health Strategy, which the European Union sort of commits itself to deliver better health services, better health and well-being of people across the life course. We have highlighted 20 guiding principles within this one, and the first guiding principle is to address poverty in line with the SDG #1, addressing poverty, taking cognizance of the fact that health is determined by many other things, but within the healthcare sector, we have to do the best possible to treat people once they're sick, and make sure that once they're sick, they have got actually equitable access to these services. With this, I would like to leave it as an introduction. I hope I haven't confused people more than there were already before, and will actually hand over then to Joe.
You have these two questions you wanted to run.
Oh yeah. Before maybe we go to the two questions.
Two more questions.
And Joe will pick them up either before, during, or after his presentation.
Okay.
The first question reads, does starting a health insurance with a formally employed population group contribute or detract from equity issues? And the second question is, COVID-19 and the ongoing Russian invasion of Ukraine has had global fallout of the world economy. What specific consequences are likely to affect progress towards universal health coverage and the ability of governments to implement pro-poor policies?
So again, perhaps
give you a minute to answer these questions before then Joe takes over and sets up his screen, and I will allow him to either address the answers before or during his presentation.
yes, maybe Joe wants to discuss the answers.
Yeah, well, just to say, I think for the first question, I think it would be interesting to see what people say, and we can probably even come back to it after the presentation from Morocco as well, and see where we go, because like hopefully any good question, the right answer is it depends, and that's what we should be discussing. In terms of the second question, yeah, it's really to think about a little bit what you talked about yesterday. What specific features of the changes in the world economy, thinking of economic growth, poverty, fiscal, things like that, why, how might those have some impact for what governments do? And I'll come to some of that in my talk, so that one we can perhaps discuss at the end. So if I can share now,
Yes,
is that okay, or do you want to leave that up?
Okay, it was just to give you a sense of some of the answers coming up.
Oh, okay. Let me look. Sorry.
Indeed, you can see that we have already a number of respondents. So
Great.
a little bit of an idea before you start presenting.
Excellent.
Okay. So over to you, Joe Kutsin from WHO, and please share your screen and display your presentation. Thank you.
Okay, good. Great. Well, thanks, and thanks for giving me this opportunity. I'm just going to try to get this into presentation mode.
Slideshow, perhaps.
Yeah. Why? There we go. Good. So you can see and hear me okay? So I'm going to talk about, and Bernd referred to it, universal health coverage and some of the equity challenges. One thing to say up front, given some of what Bernd had said, is that universal health coverage, or UHC, is not the same thing as health, right? And that's an important issue to remember. It can contribute to better health, but there are other, let's say, political dimensions of this, and it does more in the space of what might be deemed the social contract in terms of what people get. So my focus is going to be very much within the health system, because there's a lot of resources there, because this is an important area of intervention, but it's not to say that it's more important as a determinant of health than other factors as well that Bernd highlighted. So in this talk, I'm going to give a bit of a definition, an overview of the concept and what it means for policy. Given the focus of the week, I want to talk about measures and trends and what's driving things. And then this last point, which was really around the second question that you just looked at, how is what is happening in the world now heightening the challenge to address equity considerations? And then very briefly on what some of the core directions that we're seeing that are useful, but we won't go into detail on the policy responses. So the definition that we use is here, that basically everyone, meaning all people, without discrimination, can get the services they need. Those services need to be good enough to improve people's health. And in doing this, they should not have fear of financial hardship as a consequence of the need to pay for care. So this is basically a normative position that is agreed in the sense, at least through UN resolutions and in many national constitutions as well. Not my own, if you can tell from my accent. I have been in, I think, Europe long enough to have lost sufficient weight, so I'm not one of those that Bernd was referring to before, but just to say that's the case. But to emphasize that actually UHC itself is a set of goals, and it is a normative set of goals, right? And so one way of thinking about it is to what extent The political question is almost to what extent are countries willing to pay for this? And what we see in practice is that varies quite a bit. It's confusing at times to talk about achieving universal coverage because no country, not even the richest countries, have fully achieved those objectives. So to make this practical and useful, we talk generally about moving towards universal coverage, which is really to look at the three objectives that are embedded in that definition. First is clearly equity, right? Reducing the gap between the need for services and the use of services. So this is equity in service use, improving quality so that those services make a difference, and improving financial protection so that, again, people are not forced, to make that choice between their money and their life when faced with the need to pay for care. In simple terms, we sometimes kind of combine the first two and say, what we're really trying to do is reduce unmet need and reduce financial hardship for people who do use services. Okay, so this is important. This idea of going from the achievement to improving makes this something that is relevant to all and enables you to kind of go from this broad kind of statement to saying, right, what's the direction for progress over the next 3 years, over the next 5 years? What are our priorities in that sense? So to be able to make this practical and useful. Now, what does it mean in terms of policy? The idea of having coverage as a right is a major shift in a sense in public policy. And I argue it came after the Second World War because public policy on health coverage effectively started in Germany in the 19th century under Chancellor Bismarck, where the objective was not universal coverage. The objective was industrialization, militarization, and so on. And so given that objective, the coverage programs focused on the industrial workforce, right? And the idea of universal coverage really came as medical technology improved, and as the ideas, especially after the Second World War, the ideas that you espouse on social cohesion, for example, came more to the fore, with the idea that everybody actually should get the services they needed. It doesn't matter if they're a worker or not, or if they're in salaried employment or not. And so in practice, or in concept, although not always in practice, this should have had important implications for decisions that countries make, both on the sources of funds for health systems and the basis by which people are entitled to services. The other issue, which is also very important, is that when we say all people, we're not talking about all insured persons or all people of a certain group, right? That everyone means everyone. And so as countries implement various schemes and programs, what needs to be measured and considered for policy is not just the impact on those who are the beneficiaries of that program, but the potential spillover effects. So the unit of analysis is really the entire population. Right. And the reason is, and I'll show in a second, that basically a scheme or program can make its members better off at the expense of everyone else. Right. So this is not something we want to do. And last, and as I said, to actually match resources to needs requires redistribution. If you think of the diagram that, or the picture, the image that Bernd showed of the three people and the three stools, I guess the analogy I would draw with the need for health services is that that need is not distributed equally across the society, right? We don't know in any given year who are going to be the people who are going to have, suddenly have an accident or develop a condition and then need a lot. So we want to have a health financing system that is able to redistribute to where those needs are. Very different from then when talking about savings or pensions where that issue does not arise, right? So this is the point about pooling funds and being able to redistribute. Okay, as an illustration of the measurement, I do this a lot, which is to look at, in this case, we're looking at the percentage of the population in these countries that are affiliated, have some sort of private voluntary insurance. And you can see that ranges from some quite high to quite low. But then related to that in the middle column is what share of overall health spending flows through that voluntary insurance. And what you see in France, Slovenia, and the UK is that that expenditure share is much less than the population covered. And the interpretation I give to that is that that coverage is not having any major potential harmful spillover effects. Yes, it's unequal in the sense that in the UK, for example, people with private insurance do get faster access and so on, but it's a kind of political price they're willing to pay. And at least at the time of when these data were collected, it doesn't have major considerations for the rest of the country. But if you look at Kenya and especially South Africa, where this has been best documented, you've got about nearly half of health spending flowing through private health insurance that only serves about 16% of the population. So those 16% are doing quite well, we'd say, in this regard. But in a wider context of, scarce human resources for health, in particular, this arrangement tends to be a drain on the rest of the system. That only, in a sense, 53% of the resources are left for 84% of the population. And so, in a sense, if we're only kind of leaving that private insurance alone, we're not dealing with the real issue, which is the spillover effects that this is having in terms of the availability and quality of services for the rest of the population. Also, because other factors, such as the fact that the prices in that sector are very high, and that drives up prices everywhere. So this is a concern that even though we have different schemes and programs, it is still a system, and those schemes and programs are connected to each other and have often unintended effects. So the unit of analysis is really critical when we think about measuring things. Okay, so now coming to some measures, and most of what I will share is from these two reports are the report we do jointly with the World Bank on global monitoring of universal coverage, and then an additional one that goes into more depth on financial protection issues. Broadly speaking, what we measure, and I'm going to come back to some of the shortcomings of this, are the SDG indicators 3.8.1 on service coverage, which is meant to reflect that goal of everybody getting the services of good quality that they need, and 3.8.2 on financial hardship, that basically people do not suffer severe economic consequences as a result of the need to pay for healthcare. Okay, so the way that service coverage is measured, and this first point, just to be clear, and I often make this point, that it's important to never confuse the indicator with the objective that it's meant to be measuring, right? If an indicator was a perfect measure of the objective, we wouldn't call it an indicator, we would call it a fact, okay? But it's not a fact. It is a proxy. It tells us information. It's imperfect, but it just needs to be handled with care. In the way that the world has agreed in a global sense to measure service coverage, it's broken into these four categories. In any one country, it's important to say, well, what matters in our country? What are the important elements? And you might want to modify the global measure to do something that's much more country tailored in a way. And what we see, this is just some data, and basically without going into detail, green is better, right? And orange is worse. And so what this is saying is that there's more countries in green over time, that between 2000 and 2019, service coverage appeared to improve in most countries of the world. Okay, there's a lot of reasons for that, but the core reason is very simple, that over that time, and this is again the 20 years prior to COVID, there was overall broad economic growth in the world. Yes, there were variations between countries, but very broadly speaking, we saw this pattern, and we saw that relationship with the service coverage index, which is on the left, and actually also with life expectancy. You might expect it to be even higher with life expectancy, given that would capture, maybe things like nutrition and other things like this that obviously contribute a lot to life expectancy. Okay, but understanding the drivers is important when we come to, in a moment, what's about to change. Now, one shortcoming of our indicators is that, with few exceptions, and this is one, they're not very good at measuring inequalities within countries. Because of the Demographic and Health Survey, we do have some disaggregated data for reproductive, maternal, neonatal, and child health. And what we're seeing here, and what those arrows are showing, is that if you look at in the middle, let's say the economic status group, that this is divided between the lowest quintile and the highest quintile, or the poorest 20% and the richest 20%, you see very big differences within low-income countries in terms of service coverage. Those differences are not as, they still exist, but not as much in lower middle-income countries and upper middle-income countries. And similarly, we see differences by education status as well. So there are some data that are disaggregated, but it's just for this set of services. And the reason is really you need household survey data to tell you something about this, where you can link that. And it's generally, unless you have a very specialized survey, as is the case with these reproductive and maternal child health surveys, it's very hard to link health-specific service use to either economic status or other variables. Okay, but we have it for these services. Now, on financial protection, we have, this is a concept that, broadly speaking, we are concerned also that people, we're looking at not just expenditures for people who use services. Actually, that is what we look at. So for those people who use care, did what they pay cause financial hardship? What that misses is all of those people who don't use care because they thought they couldn't afford it, right? So to some extent, the measures that we use don't capture that. And that's why you need to look at these two measures together, both service coverage and financial protection, okay? And basically, again, that's why we need to look at both of them. What this is showing is a combination of the two. And basically, on the vertical axis, starting at the top from 0 going down to 25%, is the percentage of the population that experienced financial hardship as a consequence of paying for care, right? And going from left to right is the service coverage. So you want to move towards the right. The upper right would be ideal, as this green arrow says, which is higher service coverage, less financial hardship. What we see in practice across all WHO regions over time is basically service coverage improved. We see a lot of movement from left to right over time, but financial hardship actually got worse in most places, except a bit in the Americas and to some extent in Europe, although it's not so clear when you break it down. Now that is actually quite intuitive, that basically people had more money, they got to services more, so that improved service coverage. But it could be very, it's plausible that once they got to those services, either they paid something out of pocket or they got prescriptions that they weren't getting before or so on. So it's a kind of a normal thing one would see, that with income growth, service use can improve. And if policy doesn't respond or public spending doesn't respond, you can get this worsening of financial hardship. Now, the issue, and I would say for your thoughts and discussions really, is that what we're not doing very well in these global indicators is capturing inequalities. As I said, because there's not a lot of the disease-specific things are hard to capture from household survey data, and we're not simply looking at, as I said, easier but still quite important things like simply, inequalities in outpatient visits and inpatient admissions, right? That would be actually quite useful to look at country level. And because of the way that we measure financial hardship, which is simply saying of a household's income, did health expenditure exceed 10% or 25%, that actually understates the impact on the poor, because the poor devote a larger share of their income to meeting basic needs, meaning that they would have a less disposable income. So without adjusting for basic needs, we're actually understating the hardship that the poor are facing. Right? So this is a concern with the global measures. I think the good news is that you can do more sophisticated measures with the data that exist, and our European regional office in particular has done this to assess things in this way. So for example, using some survey, the Eurostat survey here, they looked at reported unmet need for prescribed medicines, right? So not disease specific, but for prescribed medicines, and in this case by education status. So you can see this is one way to show disaggregated data. And again, you're based in country, so you need to think about what are the variables that matter in a sense politically from a policy thing, or maybe unstated, but you want to put a light on, and seeing if there are survey data or you can support generation of survey data that might help in that respect. And then the measurement process, or how to measure, also matters. As I said, we've got this straight budget share, which is good for generating global levels, but not very good at equity, basically because of not capturing the capacity to pay issue, but effectively saying everybody has the same capacity to pay, and 10% of a rich household is the same as 10% of a poor household, right? So there's been different attempts over time. We had in the past had an adjustment for food, which was crude, but okay. In Europe, there's a kind of a normative basic needs adjustment, which our team believes is more policy relevant. And part of that is showing how. This is data from Latvia, where what this is showing, the darkest color is the poorest 20%, the lightest color is the richest 20%. The overall incidence of catastrophic expenditure went from 10.1 to 10.6 to 12.9. But what they showed is that in 2000, after 2009, they had exemptions for the poor introduced, and it seemed to work in 2010, that we saw the poorest had less catastrophic expenditure, but then the exemptions were abolished and we saw them rising again in 2013. So this is again saying how you might tailor your measurement approach to the specific policies that a country is doing, and use a way of measuring that is better at disaggregating the impact on the poor. Now, going forward, and based on what we know from the historical data, that if service coverage and really service use patterns are driven largely by income growth, income inequality and poverty, and financial hardship is driven also by these things, but also public spending and public policy, what do we expect to happen with these kind of contextual drivers of progress in the coming years? So this was your second question, and we'll need to look at the word cloud later. But basically, this is what we are anticipating and have done some writing about, which is that we expect overall, on average, service coverage to slow with slower economic growth. But because we're seeing around the world increased inequality and increased poverty, that we would expect inequalities in coverage and financial hardship are likely to increase. Even though we're not capturing it well, it doesn't mean we stop thinking and using our heads and common sense into expecting what will happen. Now, government needs to respond, but the increased debt service that countries have taken on is likely to constrain fiscal space for any type of public spending, including for health. And so all of this is really not good news for UHC and for equity in particular. So we need to do something now and not wait for the data to come in. I think we can have a pretty plausible idea of what needs, where we need to prioritize. Because if there's no response, we're going to likely see this stagnation and widening inequalities in both service coverage, and really a concern of whether or not we take UHC seriously. And the fact that, again, as I said at the beginning, equity is really hardwired into the concepts. In terms of responding, a lot of the noise, especially with the fiscal constraints that we see, are about the massive funding gaps for UHC. But behind that is kind of a misconception of UHC being equal to the SDG targets, which is about crossing some arbitrary threshold, rather than, and that we are then thinking in desperate ways about how can we get money, how can we even use whatever is meant by the words innovative financing, how can we get more money into our system? And the reality is, in practice, there's a lot of bad experience with things. I mentioned voluntary health insurance before, even in context of very low labor force formality, when you're trying to do contributory health insurance just for the formal sector, it can raise money, but it widens inequalities and can deepen inefficiency. There's also a pressures to kind of deal with short-term problems, bypassing bypassing institutions, the people who are actually going to need to be monitoring and adapting their systems. So the main issue the main message here is to not lose our heads, to stay focused on what works, to keep building the institutions and support countries to actually focus their resources on the people with most need, right? Now, to make that happen, and the promising directions we see are to move away from contributory-based entitlement. Some countries have done this. We've recently published something on Burkina Faso, Niger, and Burundi, where they moved to make maternal and child services in government health centers free. And they were not just a declaration, right? What made that work was shifting the entire approach in public finance from an input to output orientation. A lot of changes in public financial management that, you know, instead of saying we pay salaries and medicines and utility costs, it was like, we're paying for this benefit. And you at the provider level, you can reallocate your funds. You have to report your expenditures, but you're accountable for delivering these services, not just for spending all your budget lines. Right. So this is about a pathway of coverage expansion that is not about enrollment in insurance schemes, but through gradual extension of services with a way that is focused on the poorest part of the population. And the other thing, which I think is to not, in doing that, not set these also up as parallel programs, but look at how to kind of mitigate the risk of fragmentation. If you can't merge everything in one, can you do things like make your data systems either interoperable or unified so that you establish a common analytic framework? You're able to analyze at the level of the whole system and population and not just the scheme, not just to do that, but to lay your foundations for next steps. So to summarize all of this, again, it's the idea that equity is part of the concept of UHC. The way that we're measuring it globally is okay, but it really undervalues and understates equity as a concern. The consequences of COVID and the war are going to likely heighten those equity challenges. And I think without going into, you know, there's no universal thing of what to do for countries, but certainly prioritizing equity in both the monitoring and policy attention is really essential, both for countries and agencies such as ours and yours, if we're really seriously committed to UHC. So with that, I'll end and thank you. And just to say that I think many of you know, we've benefited greatly from our partnership with the Commission under what's called the UHC Partnership Program. You have resources in your countries through in the country offices backed by our regional and headquarters teams. And of course, there's a very strong commitment to work together with you on this agenda. Thanks.
Thank you very much, Joe, for especially for the presentation, but also in particular for the last sentence, because that's what I would have said now as well. And I want to go back to my introductory remark in terms of measuring. I think if we engage in development policy, it doesn't matter which sector we are engaging and focusing, we should be actually measuring the impact of whatever we are doing on the health of people and the welfare and the well-being of people. So whether it is nutrition, whether it's transport, whether it's energy, whether it's climate, we should make sure that we measure those activities in those specific sectors which are unrelated on the first glance to health, to see that they are not worsening health indicators, but maybe could be used to actually contribute health indicators. And those delegations who do not have a health focal point can always refer to the Universal Health Coverage Partnership Program, which we are supporting WHO to implement. There is actually a dedicated person in more than 119 WHO country offices, which every delegation can have access to and can approach and sort of engage into a policy dialogue. How is the health situation in this particular country? And what is it that we can do and contribute and relate our program to in this country, understanding the country context. With this, I will hand over to Olivier and sort of hope that we sort of highlights this country context at the example of Morocco. How did the European Union sort of contribute addressing inequalities in health in the Morocco context?
Thank you, Bernd. I'm sharing my screen. Oh, I'm not able to. Just one sec.
Go to presentation mode. I think that's easier.
J'arrive pas à démarrer ce truc.
J'ai mon micro mis. Just one second. Avoir le diaporama. Mon truc de représentation.
Okay, good, excellent. We hear you well. We see it perfectly.
Can you see my screen?
Yes, very well. All good.
Okay, sorry for that. So this presentation has been put together by Baptiste Mondouz, who is the health officer in charge of the health portfolio in the EU delegation in Rabat in Morocco. Baptiste this morning is busy as his ambassador has an audience with the Minister of Health, which is an important time for the dialogue with the government for the EU in Morocco. And that's why he asked me to make the presentation. I'm very happy to do that, and I'm going to try to be to do it as faithfully as I can. Morocco is a lower middle income country. I think that the GDP per capita is something like $3,700. The population is 37 million. Access to healthcare services is a hot topic at the moment in Morocco, as the king himself has launched a couple of years ago and is still supporting a major social protection reform aiming at making quality services available to all through the generalization of the health insurance and the strengthening of the public healthcare delivery system. The reform takes place in a context marked by an ongoing epidemiological transition. Non-communicable diseases are the main cause of mortality, and the context of persistent inequalities. The Moroccan health system is a classic tiered system under the oversight of the Ministry of Health, which has recently become the Ministry of Health and Social Protection. Public, tertiary, and secondary hospitals are run as autonomous institutions, while primary level facilities are managed by the Ministry of Health and have limited, if any, autonomy. Overall, there is a strong discredit on the public healthcare system in the population. And the first choice for everybody who can afford it is to seek care in the private sector, which, as you can imagine, is booming. Sorry for that. A 2002 law on basic medical coverage established two main social protection schemes: a compulsory health insurance called AMO, Assurance Médicale Obligatoire, actually introduced in 2005 for employees in the formal sector and pensioners. This scheme gives access to healthcare in both the public and the private sectors. A medical assistance scheme called HAMED, directed to the poorest, roughly a third of the population, was tested in 2008 as a pilot in a region before being scaled up to the whole country in 2012. It has recently merged with AMO to become AMO Solidaire. And the people working in the informal sector are also progressively included into this AMO, this health insurance. So we are really at a critical point where the health insurance is about to cover the large majority of the population. Looking at some key health indicators, you can see some of these at the right side of the slide. You can see that Morocco has made significant progress over the last 10 or 15 years. And Morocco does no longer lag behind the average observed in the region or in similar countries, or countries with similar levels of resources. However, in terms of Human Development Index, progress is slow, and Morocco still ranked 123 in 2021 compared to 130 in 2011, with a lower decrease of the index when adjusted to inequalities as compared with 10 years ago. Interestingly, the inequality adjusted life expectancy index is higher than the inequality adjusted income index, which is closer to the consolidated index. This suggests that some local mechanisms buffer economic inequalities. Morocco has engaged early in consolidating its national health accounts, the last round of which took place in 2018. According to the last National Health Account report, households through direct out-of-pocket spending remain the main health funder, contributing to nearly half of the total health expenditure, 46% precisely, which is 5 points less compared to 2013. This level of direct out-of-pocket payments is almost the double of the international recommended threshold. The slight decrease in out-of-pocket payments is explained on one hand by the extension of health insurance coverage, the IMO and the RAMED, and on the other hand, by a series of actions taken by the government to reduce the price of drugs, including the extension of the list of reimbursable for free medicines, and the promotion of use of generics, for example, and more efficient purchasing mechanism. With the social protection system in place, the poorest part of the population theoretically benefits from free healthcare services. In terms of financing volume, however, the bulk of the health expenditure is borne by the urban, middle, and upper classes who turn to private providers. The second source of health funding in Morocco is labor-based and voluntary health insurance, which covers roughly 40% of the population. That was the data in 2018. And this mobilized approximately 18 billion dirham, roughly 2 billion euros. And this represents 29% of the total health expenditure. This is an increase of 6 or 7 points compared to 2013, possibly reflecting how the economic growth of the country allowed the creation of more jobs, leading to more people affiliated to the healthcare prepayment mechanism. At an almost similar level, roughly a quarter of the total health expenditure is a government spending on health that also includes the RAMED, the health assistance to the poor. Government health expenditure as a proportion of the government general expenditure has increased over the past years, reaching this year 7.5%, which is still far below the Abuja Declaration target of 15% and below the WHO recommendations. Consolidated health expenditure, government and insurance represent 5.3% of GDP. This is $176 per capita and per year. This is more than what can be observed in low-income countries where many of you are working, but this is in reality extremely low, much too low to pay for quality healthcare services for all. The single fact that half of the bill is currently paid by the household is telling. Development assistance allocated to the health sector is marginal in Morocco. The slide shows 0. In fact, it is 0.2%, and this figure tends to decrease over time. Such a low figure calls for remaining humble regarding the impact of our cooperation. It also calls for engaging a reflection on how best budget support and technical assistance can foster policy dialogue in the health sector in this context. This slide illustrates the current commitment of the government to improve access to health services. Public funding has been increasing, as I said, by about 10% per year between 2011 and 2021, and additional efforts were made in 2022 and this year, with 20% increase each year. This increase in the last 2 years is mainly due to an increase in capital investment. This is a green block in the figure on the left. Efforts have been focused on building or rehabilitating health infrastructures, new hospitals, but also more than 1,500 primary healthcare facilities across the country. This investment also served for increasing the capacity of the training institutions and for developing a new health information system. Recurrent costs still represent approximately 70% of the budget, the blue part, the blue blocks, with a large part allocated to salaries, the light blue in the figure. Every year, the Ministry of Health opens something like 5,000 additional positions for different categories of health staff, which doesn't mean they are able to recruit that number of additional health workers, as we will see later. So clearly, there is a big push made by the government in the health sector at the moment. Despite all these efforts, the lack of qualified personnel remains a key constraint for any attempt to improve the availability and access to health services and to tackle inequalities. The current health reform foresees an important increase in all categories of healthcare workers, 5-fold for nurses and 3-fold for medical doctors and pharmacists. The objective is to reach 45 healthcare workers per 10,000 population by 2030. It also involves changing in their remuneration and a number of attraction and retention measures. It's clearly going to be a complex and challenging endeavor, as besides this dramatic increase of the production of HR, Moroccans will have simultaneously to secure the retention and motivation of this workforce, but also to equitably to deploy these staff across the country. The launch of the EU Global Health Strategy in 2022 provides a robust strategic framework to pursue our partnership. However, the current context of the EU calling for migrant workers, health workers, to address its own workforce gaps may confront us with an ethical dilemma requiring to better balance both sides of the partnership. In terms of inequalities, data are essential to document health inequalities, but also for their interpretation and analysis. Building on the issue in 2018 of the National Health Accounts and the Demographic Health Survey the same year, the Ministry of Health partners with WHO to produce an analysis of health inequalities. These data have formed the basis for policy development to tackle inequalities and for the dialogue between the EU and the government in the health sector, for instance, documenting to what extent budgetary allocations and priority orientations look effective to reduce inequities. The analysis breaks inequalities into 5 main categories or themes, and in each of these themes look at inequalities across several dimensions: demographic, geographic, economic, the level of education. Rather than absolute deviations or ratios which simply evaluate the difference between the minimum and maximum variables, it uses such statistics as concentration indexes and dissimilarities indexes to analyze more into detail the distribution of variables, allowing to raise questions and to feed discussions around priorities and how to best address needs. Let's have a look at some findings and examples. If you look at the life expectancy at the left side of the slide, you can see significant discrepancies in all dimensions between rural and urban population, between male and female, depending on the poverty quintiles, and between regions. The later dimensions, the geographical dimensions, is where inequalities are more pronounced. Indeed, the average life expectancy in the region of Rabat, the capital, is close to 80 years, when it is 7 years less in Drata Filalet, a region located in the south of the country. The figure on the right side of the slide shows progress over time for neonatal, infant, and the 5 mortalities. As you can see, all curves are decreasing between 2011 and 2018. This shows progress. However, there is a persisting gap between the highest and the lowest quintile for the curve at the top, and the same gap persists for rural and urban populations, the curves at the bottom. Probably thanks to the adoption of the MDGs in 2000, maternal and child health has been at the top of the agenda since 2000. In Morocco, considerable efforts have been put on improving access to essential obstetric and neonatal health care. This is reflected in these figures, where you can see an improvement over time of the coverage of 2 MCH services, CPN, and and the deliveries attended by skilled health workers. And this is both in urban and rural settings. And importantly, the improvement has been greater in the rural setting. This is a blue curves, reflecting the emphasis put by the Ministry of Health and its partners in reinforcing the services in rural areas and suggesting a decrease in this dimension of health inequalities. Interestingly, 2 indicators of the EU budget support programs that was implementing during this period of time have been directly targeting this inequality dimension, with a 3rd indicator more focused on securing the quality of the care provided in rural areas. The delegation has been focusing on such geographic inequality for quite a long time, and although it can be coincidental, we can think that this contribution to this part of the dialogue has been fruitful. This table shows the indicators which have been used for the monitoring and disbursement of the 2 last EU budget support programs in health. There is a large variety of indicators, and it may not be useful to enter into too many details. You are probably not able to read the details anyway. But there is a number of indicators which are measuring progress in areas such as improved access to healthcare in rural areas, better mother and child care, access to drugs, etc. And a majority of these indicators were defined to support a pro-equity policy. This may appear more clearly on this slide. As you can see from this overall analysis of the focus of the budget support indicators matrix, a great emphasis has been put on equity and to a lesser extent good governance across a broad array of policy priorities. Quality has also received an important attention across the board, from the availability of quality enablers to the quality of outputs. priority groups such as mother and children, as well as people with NCDs are approached through an equity lens, as are populations with special needs such as migrants and people living with handicap whose inclusion has been scrutinized. This is an example of the limitation that a pro-equity policy can face in the reality. The figure on the left shows the number of people affiliated to RAMED, this assistance scheme, remember, per quintile of poverty. As you can see, half of the 7.6 million people affiliated to RAMED are from quintiles 3 and above. So these people are not the poorest. The figure on the right shows for each quintile the percentage of people who are eligible to RAMED and the percentage of those who are actually affiliated. And you can see that in the lowest quintiles, many people who are eligible are actually not affiliated. In the quintiles 4 and 5, there are more people affiliated than eligible. This clearly illustrates how difficult it is to properly target the right people in any social protection scheme. These findings also raise questions regarding the reliability of a targeting mechanism, including its sources and value in time and possible abuse. This is one of the reasons why the government made the decision last year to change the system and to merge the RAMED population with a population already covered by the health insurance, the AMO. Since last December, all beneficiaries of the medical assistance scheme, the RAMED, are registered with the compulsory health insurance scheme, the AMO, and the state pays for their contribution. So they continue to receive free services from public health institutions. A new budget support program called Karama has just been signed. Karama is designed to support the whole social protection reform, and one of its objectives is to support the extension of medical coverage to the entire population. So as you can see on the slide, one of the variable strength indicators that have been included into the matrix relates to the integration of the extra-med population to the health insurance, to the AMO. Another indicator relates to the inclusion of the self-employed workers currently not covered to the AMO. And the third indicators will look at the reminder to be paid by the user of the health insurance. So there is a clear shift towards the support to the current reform, which aims to expand the health insurance to all categories of population. This will work and have an impact on equitable access to health services if and only if there is a performant healthcare provision system. So there is a need for simultaneously increase the performance of the healthcare delivery system across its public and private components, as well as controlling the costs through better regulation and through developing preventing dimension of care. To conclude, a few lessons learned from this experience in Morocco. One, addressing health inequalities has been a priority in the two last budget support programs in health. However, the actual impact on inequalities of the EU technical and financial support can hardly be documented. Disaggregated data are essential to measure inequalities, and they form the basis for policy choices and policy dialogue. The current social protection reform offers an unprecedented opportunity to tackle inequalities in health through the implementation of the health insurance, which is covering all segments of the population, or should cover all the segments of the population, and also through the restructuring of the healthcare provision system. This is an important dimension. In a country such as Morocco, if we accept a causality between the dialogue around the budget support and the progress recorded, it's unlikely that the volume and frequency at stake has played a significant role. There is no clearly leverage. A dialogue on health inequality is sensitive in a context where the EU contributes to the imbalance of human resources for its own health systems. And it's not only true in Morocco. Controlling costs will become more and more important in the future and require the dialogue with the government to be enlarged to areas such as health, prevention, and promotion. Thank you very much.
Thank you, Olivier, for your contribution. And I think some very useful lessons you have highlighted. As far as I'm concerned, the most critical issue you have highlighted is the one on healthcare workers and human resources in health. And Morocco being so close to Europe and having also a language, not in common, but very conversant with the language of one of the European member states, very proud of a country where we are fishing for healthcare resources. And I want to put these figures into perspective, because you talked about the aim that Morocco would like to have 45 healthcare workers in 2030. Yeah, so they want 45 healthcare workers per 10,000 people in 2030. In 25, Morocco is aiming at 23 healthcare workers in 2025. The German context where I come from, at the moment, we have 45 doctors per 10,000 population. So we have the same number of doctors now than Morocco expects to have healthcare workers in total in 10 years. And still, we are saying we need to recruit healthcare workers from overseas to address our needs. And I think there is while everybody has the right to move, the one who recruits always have to keep in mind what obligation he has towards the country and towards the individual where he's recruiting from. But it's a very, very complex and very complex issue. Thank you very much for bringing this example of budget support. As far as I'm concerned, it's an opportunity. Does not really matter so much about the size of the budget support, but that today, currently, the ambassador of the European Union, together with the focal person on health, Baptiste, is with the ministry discussing indicators, means that we are engaged in the policy dialogue, and this policy dialogue has opened through budget support, and very often is not as easy to achieve in the project mode type of engagement. With this, I would like to open the floor for questions. Otherwise, I would continue to talk, and I would hand over to Jérôme for moderating. Thank you.
Thank you very much, Ben. You don't have to give over. We can stay together.
The screen fits both of us. Yeah.
The screen fits both of us. We have the link in to the platform again in the chat. You can go back to it. Obviously, you can post your questions here. I already see a few of them that have been responded to. So maybe we want to go through some of these questions. But I see that they've been responded. So it depends whether there are new questions that are coming up, and maybe our colleagues can take the floor directly on the Zoom platform. Put on your camera, switch on your microphone, and ask questions. We can also directly ask some questions to our two guest speakers and you, Bernd, if you wish. Unless you want to add, let's read this question first. On the.
Maybe you read better, man.
Okay,
I've got challenges in reading. So.
Okay, so but I see that these are questions that were addressed to Joe Kutzin, so on the share of health spending with regards to the presentation. So this was answered. Here we have a question with regards to health being a human right, as in the Universal Declaration of Human Rights, but this is also been answered. So maybe there are more specific questions now after that.
I mean, maybe allow me a few words on this health as a human right. As a medical doctor, I've got challenges with this one, yeah? Because health is not. You cannot have a right to health. You can have a right to access healthcare. And I think a country can really guarantee this one. Health is determined by so many factors that you don't really have a right. You may wish for it, but you don't have a right. If you're smoking and you want to execute your right to healthcare, my advice as a medical doctor is stop smoking, start exercising, change your diet. Yeah. Instead of using a car, use a bicycle, not an electric bicycle, to go to the office and come back. So health as a human right. Yeah, I would really think healthcare, and I think what Joe has been talking about is access to healthcare and making sure that people have got access to healthcare at the point of need of good quality without really suffering financial hardship. Yeah, so that is what my comments to health as a human right. I would see the access to healthcare is a human right.
Just on that, I mean, I think what's important to look at is how maybe in the country that you're working in or your own country, is there something in the Constitution that can be used? In Mexico, when Julio Frank was the Minister of Health, the Mexican Constitution included what was called a right to health protection, right? And they use that both for support, develop work around improving coverage against financial hardship, including everyone, regardless of their employment status, and also on the preparation for emergency and preparedness agenda. So in a way, it was turned from just a statement in the Constitution to something they tried to operationalize. That's also been behind like the national health insurance agenda in South Africa as well, as a section of the Constitution that deals with that. So if you have that, and like I said, sadly, my country does not, but if you do have the benefit of having that where you're working, at least see how it might be used in the political engagement and transformed into something concrete.
Okay, well, thanks for that. Thanks for that addition. It's section 27 of the Constitution, and there's a famous civil society organization in South Africa named after this section of the Constitution, sort of stepping in and to advocate for people's right to access healthcare under the new government.
Okay, so we'll also see here links to other issues with the health linked to domestic violence. And to violence towards women and children. I think it's more a comment than a question, again illustrating the determinants about health and the links between health status, healthcare, and other sector policies. I think that's been made pretty clear by all of our speakers today, including you, Bernd.
Yeah, no, and I think if you come to a healthcare facility and have been victim of a case of violence, what a healthcare worker is obliged to do by his medical training is to differentiate whether that was an accident or whether there was some kind of perpetrator behind, and whether that took place in domestic circumstances or whether outside. And there is a standard how and when to involve police and or social workers to this one. That this actually contributes to ill health, be this car accidents like in the United States, shootings, which have also now swapped over to Europe, shootings and knife attacks, all much more frequent violent exercises taking place at home. This contributes to ill health is obvious for each and everybody, and that people have the right to live without being beaten up by anybody. It's self-explanatory, and I think this is as much a human right as the one access to healthcare. But at the healthcare sector, it's a limited responsibility. Yeah. Except for the fact that to notify it, to take note of it, and sort of inform the respective authorities to take the appropriate action outside the healthcare sector.
Thank you. We still have quite a bit of time for our Q&A session, our panel. Perhaps those of you who are willing to ask questions, you can take the floor. Colleagues who are in this meeting today, please do switch on your camera. This will make it a lot more nicer and a lot more lively. We can also seek to draw a few key elements that then people want to react on, and some parallel between the presentation we have received, Bernd, by Mr. Kutzin and Mr. Olivier Weil. But I'd like to for all of us, we work in delegations, we work with our instruments. I want to retain some elements, and maybe people can react about that. Those strong case made about getting good data, understanding the different perspective that we can see through the health sector about inequalities, and that to me it resonates hugely with the first day. Data is key. It resonates with the second day about with IMF presentations and CEQ presentations. So in a year we have two views being presented: service coverage and financial protection. And even though often we work in INPA, work in delegations, we tend to separate sectors, whereas we have to link up sectors to address such an issue, especially with regards to the determinants about health. We've mentioned water, sanitation, geographical coverage, your income, your poverty status. All of those needs to be understood and looked at so you can decide what to do about health. I also remember Joe's point. You either look at the overall achievements or you try to analyze and segregate specific policy measures to understand what the likely effect would be. And at the center of that, his presentation put us back to the public spending and public financial management reforms with a view on programmatic reforms and performance-based budgeting. And that to me resonates a lot with Olivier's presentation on what budget support may be able to bring to the table, irrespective of the amount of resources. What it brings is this focus on programmatic approach, performance measurement. We are measuring the performance not in inputs, but in terms of outputs and outcomes, having clear objectives that are linked to these indicators, and how public resources can be dedicated to reaching out those objectives. So it's not so much the push as to the results, and using our dialogue and technical cooperation and data to analyze what we are doing so that we can sustain that dialogue and provide goodies to our colleagues in the Ministry of Health and Ministry of Finance so that they can tackle the real issues, not just healthcare system, but social protection, water, sanitation, education. So maybe we could have a little bit of conversation around this between the three of you. That would be quite interesting.
No, what I would encourage is really to look into data, because there's no country without data. Each country has a demographic health survey, and I think Joe will know which countries these are. But most countries also have a statistical office which looks at social data. And I would really encourage each delegation, each person, it doesn't matter in which sector he is working, to make sure that he has got access to these data. And if he doesn't understand, please turn to the WHO country offices to get either access or to get a discussion involved in a discussion on this data.
I see Angelica wants to come in as well, maybe before our colleagues respond.
Well, you asked us to ask questions and be part of the debate, so that's what I'm coming in. I really think it's been an excellent presentation. I do agree with everything you say, especially around data, but I also think it is often linked to, I started working here recently at INPA and the Gender, Human Rights and Democracy Department. And of course, gender is very relevant. When we do the budgeting, I would say you need to have a gender budgeting approach. And also we know in the health sector that a lot of the medication and, you know, from the old times, it was more geared towards men and towards both in testing the medicine and how to apply it. And also with data, I find it interesting how we sometimes, you know, look at data on HIV prevalence, for example, in Southern Africa, and has it increased a lot around, we talked a lot about young girls were the main group of new infected. But then we found out that it's because young girls often got pregnant very early because there was a lot of rape in that region, or they had consensual sex but still had early pregnancies due to lack of contraceptives, and then they got an HIV test, whereas the young boys did not get tested. So the statistics were kind of, you know, lent towards more young women with HIV/AIDS because the boys didn't go to the clinics, the boys didn't get the HIV tests. I think later they started doing HIV testing in bars and at football competitions, etc., to get more holistic data. So data can also be a bit, you need to analyze it the right way. So the Global Fund, who puts a lot of money in Southern Africa, to prevent HIV. They see young girls as the target because they see the prevalence is increasing with young girls, whereas I see old men and men in general who are raping the young girls is the target. We had long debates about this, but it is still, we're putting in projects saying to young girls, abstain from sex and you'll be free of HIV and early teenage pregnancies. So I think I'm sorry to share that, but I think it is interesting with the data and how you interpret that, and what kind of data do we have around young boys who are raped? There's no data about that because it's such a stigma around it that it's very few countries that even have data around boys and men who are sexually abused. Sorry, it was just a comment, but it was also related to what you were saying. Thanks.
Joe, do you want to say something on this data issue? Or
I mean, what came to mind, I mean, I'm not an expert on the topic that Angelica was raising, but what I was hearing, because I've seen it in other contexts, is that, I'll put it this way, the data will almost never just speak for themselves. You need people to speak for them, right? That interpretation is important. And that's where, at least in trying to connect it to what I was sharing, if you look at a country like, one of our best cases, which is Thailand, it's not only the reforms they did, but they invested in developing the institutions and the people who are responsible for thinking and analyzing things. In other words, not about achieving a target indicator, but there's a group called the International Health Policy Program that is routinely analyzing things, raising, okay, what could explain these patterns or not? And ultimately, countries will not get out of dependency and short-termism if they don't have those kinds of institutions. The issue I think for us internationally is there's no SDG indicator around that, right? About having that. But this is fundamental to actual, greater self-reliance and being able to know to even ask the questions that Angelica was raising, so the idea that we're just putting out numbers and you should look at them and everybody reach their own conclusion. No, you have to actually help. Yeah, you need an informed person to intelligently interpret and draw out at least the plausible things to draw from this. Otherwise, you could use them for anything. So I think that's kind of something that we need to think about. And are we in all of the support, whether it's the budget support that you're doing? I mean, yes, one is helping the country, but are there, let's say, all of this need to come with monitoring frameworks, but not just to produce the data in the short run, but actually to develop those institutions that are responsible for actually doing public policy analysis. So that can be one of the legacies, rather than just we've got a few studies. Thanks.
Well, thanks very much for particularly pointing out Thailand. The couple of times I went to the World Health Assembly, Thailand had one of the biggest delegations, and coming there with very young people, a group of very young people doing their master's thesis, PhD thesis, but always with a group of about 100 people presenting cases there. And I think that I found it very exemplary. South Africa also has a good sort of education background within university. Even within the Ministry of Health. But I wanted to ask Morocco, I mean, is there a public health institute which takes the lead besides the Ministry of Health, with who the delegation sort of is discussing data? Because data is one thing, analyzing and digesting data and drawing conclusions is another thing. So engaging with a political dialogue between the delegation and the Ministry of Health is good, but is there also other health policy think tanks to which donors like the EU can actually turn to understand better what this data means?
I'm not sure there is really an actual think tank. There is an Institute of Public Health which is doing mostly training and produces some report. I think where the data are discussed in Morocco is mainly in the technical coordinating group, which is led by WHO and the EU delegation, and that's where the data which are available are discussed among donors and with the government. Now, to react to Angelica's comments, just want to add that in Morocco, the EU delegation is taking the gender dimension very seriously into account in the dialogue with the government, and in the design of the programs as well. In the current budget support health program, for example, among the 6 BIAP tranches indicators, 2 of them are related to gender. One is looking at the availability in all regional hospitals of specific units to the management of the victims of gender-based violence. And the other one is looking at whether the budget programs, it's a tool for the budgeting of the priority activities, include disaggregated data for male and women. So I think it's really an important dimension, which is part of the dialogue and which is reflected into the programs.
I could be very provocative. I mean, you do not necessarily need a health budget support in order to put health indicators. The European Union delegation could also think, yes, we're investing in the energy sector, in the climate sector, but at the same time, we would like you to achieve human development indicators in the healthcare sector. Sort of an indicator like we would like to make available gender-based violence units in hospitals. You do not necessarily need a lot of money. You need the policy wish to do this one. And you can use this as an indicator, even if you fund massively and heavily investments into renewable energies. So the success of your policy intervention can not only be measured in climate response or energy responses, but also said, I mean, if you drive our issue, we want to support values, a value-driven engagement, not only economic development and prosperity or sort of renewable energy, but it's our value proposition which we bring in with this one, and see whether that is possible to anchor into policy dialogue with the government. It's a little bit thinking a little bit out of the box in a policy dialogue. What affects health, what affects climate, and including energy and climate is hospitals need energy, climate need energy. We have been recently talking a lot about pharmaceuticals and access to medicines. If you want to engage if you want to support pharmaceutical industry, you need energy. So there's a lot of linkages across sectors, and we can only sort of advocate for this one and sort of offer our support in order to help people think through these ones. And I would like to emphasize again, at country level, the WHO has its country offices and has expertise within these country offices available, which European Union delegations can draw upon. To Angelica, you talk about HIV and AIDS. You know that the European Union is one of the biggest funders of the Global Fund. Yeah, so if you want to know something about what happens in the HIV sector in South Africa, yes, you can go through the country coordinating mechanism supported by the Global Fund. You can go to the principal recipients, the sub-recipients. And if they ask, why do you go there as the European Union, said, by the way, we are funding to you to X%. Yeah, and if you take the European Union together with its member states, then we are in the Global Fund, we are the biggest donor after the US, yeah, at the same level, so 30 to 35%. The same is true for Gavi. So there is a mandate in engaging in the political dialogue, even if from the bilateral country program, there is no investment in health.
I respond to that. I think you're actually raising a very important issue. I was chairing the coordination country mechanism for the Global Fund, and it is an excellent, I think every EU delegation should be part of the CCM in every country we sit, because of the amount of money we invest, and because it is looking holistically on a participatory approach to health. And I know the Global Fund invests a lot in solar energy in clinics and hospitals. So obviously, yes, health is very linked to climate. And I suppose most health sector workers within the EU delegations do work with the Global Fund, right?
I would wish there would be a lot more taking on the co-chair of a CCM. I was doing this in a different function also, and I found this incredibly rewarding. But many actually are shying away. And when the Global Fund comes and wants to visit the country, they are not being often very well received by colleagues from the European Union delegation. And the same is with WHO and the Universal Health Coverage Partnership. 119 focal persons we are funding in respective WHO country offices. And often one hears that they reach out and want to talk with the EU delegation and there is no interest. And I think especially with data, I think in the post-COVID area, every delegation should be interested in health data, even if they don't spend anything in the health sector, but relating whatever they are doing in terms of development cooperation to health, I think is an obligation in a post-COVID world. Yeah, and look into that. If you don't understand the data, please ask somebody to help you to interpret this data. Yeah, and there the WHO is a perfect entry example. And if you talk about Team Europe, yeah, there's most likely in every country the European Union member states who engages to some extent in the healthcare sector who one can really draw on. Is making these linkages between development cooperation and health. And there's no sector, no topic I cannot really make a link. That's the reason why I'm perfectly happy with the inequality marker, yeah, to force people to think about these impacts and give it a think. Inequality, disability, gender. Yeah, what is it that this action actually impacts on? And if people have challenges, that is what thematic units at headquarters are for, to support delegations in creating these linkages. Yeah.
Resonating strongly with Angelica.
She's in G1 and I'm in G4, so it's
excellent. Perhaps I don't know if Joe or Olivier wants to have a last words and last key lessons they want to draw from these presentations for colleagues on how we can use the marker, how can we can use our dialogue to get the issue of inequalities in health better taken care of in the countries where we work.
I think I would just like to insist on something very simple and obvious. I think at the moment in the dialogue, we are talking a lot about health insurance coverage, universal health coverage, and as a coverage, but we may miss something obvious, which is that to provide access to healthcare, you need to have healthcare available. And in many countries, health services are just not available. HR is a major constraint, but there are other aspects which are missing. And there are still a lot to be done in a number of countries to strengthen the healthcare provision system. That's still a big job to be done, and the EU has to contribute to that.
Thank you for that, Olivier. Even to establish the healthcare system so that something exists in all regions and provinces or districts. Joe Kutsin, you want to have a word?
Yeah, well, just to follow on that, it strikes me that, and I see this in WHO as well, that people are fascinated by finance and financing reforms and issues. And I mean, I spent a career on it, but the issue is that's not necessarily the main thing, as Olivier was just saying, and that there's nothing you can do with your financing reforms that will fix the human resource shortage. You have to actually invest in human resources, right? So it's important to have a good diagnostic of what the problem is that you're trying to solve. And similarly, when we deal a lot with countries with highly informal economies, we're pretty strongly against the idea that you try to get everybody to enroll in some sort of insurance scheme and have hundreds of schemes. The issue is, how do you get services to people who can't get to services, right? And think about how you're going to do that on the delivery side, and then think about financing after, I would say. Last thing I think I would say, just coming out of the discussion you were having about the data, and you mentioned something about connecting to statistical institutes. I would imagine that your support comes with some leverage that you've got in terms of saying, okay, what sort of conditions may be too strong a word, but something that you want to see happen. And if there's a commitment to really looking at the inequality issues, one thing that I think we've been able to do in selected cases, the World Bank has done in selected cases, but it's still not systematic, is, as you said, every country has a national statistical agency. And what's been possible in some cases it's still a cost, but a marginal cost, is to say, can we periodically do a module on X topic? You know, maybe it's healthcare expenditure, care seeking behavior, status, whatever that happens to be, and do that every 3 years or something. So it's attached to the National Household Survey. It links to all of the socioeconomic, the other kind of data that you would want for doing equity analysis. And you start to build that in on a regular basis, and not so highly detailed that we do a different survey. Like in the health sector, we're very fragmented. We want to do something different for every disease, right? And every condition. And the issue is, you know, to try to get hold of that. Some of that problem comes from my organization. But in any case, think about how you would not just do a study, but how might you start to institutionalize a process where this becomes part of what gets routinely done. I think in Indonesia, they've had on their own a regular, not only a regular household survey, but a kind of rotating set of modules that every few years there's another one. So over time, you generate a lot of quite useful information for policy. So just to think about whether something like that might be possible to initiate in some cases or support in the context of the support that you're bringing to countries.
Thank you very much, Joe, and making this last call on how instruments, budget support building institutions and processes that will sustain the good use of financings towards policy objectives.